Hello everyone. Today we are going to start with the first lecture on the basics of physiology of ventilation or the lung mechanics. My name is Dr. Manisha PH. I am the consultant neonatologist. A good understanding of the unique physiology and the pathophysiology of the newborn respiratory system is required so that we can provide a newborn-centric care which will optimize the pulmonary as well as the neurodevelopmental outcome for the babies. The newborn respiratory system is a complex organ as well as a very fragile organ. It is comprised of two functional areas. One is the conducting system, which is from the nasal passages till the bronchioles, and second one is the gas exchange system. The gas exchange system comprises of respiratory non-cartilaginous bronchioles, which will lead to again the alveolar ducts, alveolar sacs and alveoli. Let us now look at how the spontaneous respiration happens in newborn babies. Let us look at this Boyle's law on ventilation, which says that at a given temperature, the volume of the gas is inversely proportional to the pressure. So what happens? Air, as it like a liquid, moves from a region of a higher pressure to the lower pressure. So during the breathing and just prior to the inspiration, no gas flows because the gas pressure within the alveoli and the outside atmospheric pressure is at the same level. For the inspiration to occur, as you can see in this picture, the alveolar pressure has to be lesser than the atmospheric pressure. And for the expiration to occur, the alveolar pressure has to be higher than the atmospheric pressure. Thus, for the inspiration to occur, the gradient in the pressure which can be achieved by lowering the alveolar pressure, and that is a negative pressure ventilation which is in our spontaneous breathing, which is natural. A mechanical breath as opposite is a positive pressure ventilation, which is a mechanical breath. It's not natural. So you look at these pictures, you can see the atmospheric pressure when it is 760, the inside alveolar pressure is 757 for the air to suck inside. And this causes the diaphragm becomes contracted and the ribs and the sternums are raised. In the other picture where you can see the expiration is happening, the inside pressure is 763 and outside pressure is 760. In this, the diaphragm is relaxed and is arched upwards and ribs and sternum return to the original position and the volume is decreased. So this is a negative pressure ventilation which normally happens. So that is how the mechanism or the breathing happens. Now let us look at the phases of the lung development in the newborn baby. It starts from the embryonic phase till the alveolar phase, which goes up to 3 years of life. So embryonic phase is the first phase, which is between 3 to 6 weeks and where there is a development of the proximal airways. Then comes is a pseudoglandular phase where there is a development of the conducting airways. Then comes is a canalicular phase where there is respiratory bronchioles are formed and alveolar ducts are produced. The majority of the babies which we receive in the NICU or the premature babies are in the saccular stage of development from 27 weeks to 36 weeks where the actual gas exchange starts and the alveolar starts developing. The last but not the least phase, which goes up to 3 years, is the alveolar phase where the multiplication happens and the septation happens. The respiratory distress syndrome, the bronchopulmonary dysplasia, the pulmonary interstitial emphysema, all the problems are generally happening in the saccular phase of development. So in utero, the lung is a hydraulic fluid-filled system, and this respiratory system develops as a laryngotracheal groove from the wall of the foregut, which is closer to the fourth and the sixth pharyngeal pouch. Now let us look at the difference between the adult airway and the infant airway. You can see in this picture, the nasal passages of the newborn are easily blocked by the secretions and their mucosa is very, very thin. They are obligate nose breathers and their close proximity of the soft palate is to the epiglottis. The mouth breathing happens only during crying. And obligate nose breathing is very vital for their respiration during feeding. 50% of the airway resistance in newborns come from their nasal passages. If you see in this picture, the larynx is at the level of C4, C5 in newborns as comparable to adults, which is at the level of C5 and C6. The shape of the larynx is funnel shaped and in adults it is cylindrical shaped. The important thing which you have to understand is the narrowest part of the larynx is at the level of cricoid cartilage, that is below the vocal cords. But in adults, it is at the narrowest at the level of the vocal cords. Now, why this is important is when you are putting an endotracheal tube, it may cross through the vocal cords, but it may get stuck in the subglottic region because that is the area it is the most narrow. The cricoid cartilage is circular and complete, and that's why the tube is generally nicely fitted, so there is no need of cuff tubes in these babies. Also, the laryngeal cartilages are very soft and collapsible. What you have to also understand is tongue is relatively very large in newborn babies as compared to adults, and their vocal cords are slanting anteriorly as compared to the adults. They have a short neck and they have a occiput which is rounded. Now, all these things are very important for us to decide which kind of blade to use when you are intubating the children. So straight blades are very helpful in newborn babies because we have to displace the tongue and the soft tissue forward, which does not happen in the curved laryngoscope blades, which is the Macintosh blade. The curved blades are designed to put it in the epiglottis and posterior pharyngeal wall, a space called vallecula. It doesn't push the lung forward, the tongue and the forward and lift the soft tissues. So it's important that we use a straight blade because the larynx is more higher in the neck. They have a short chin, short neck and large tongue which you have to displace, which can be done easily with the straight blade. Now let us look at, after we have finished now with the anatomy of the newborn airway, let us look at the physiology. This is a diagram which shows you the lung volume and the lung capacity. The neonate has a very limited respiratory reserve, that is the inspiratory reserve, the expiratory reserve as well as the residual volume. The most important thing here is the FRC, that is the functional residual capacity, is the volume of the lungs which are present at the end of the passive respiration. And this is the air at which, this is the capacity of the air where the pulmonary vascular resistance is the least. And this is very, very low in the premature babies. So you can see the normal values of the lung volumes in the newborns. The normal FRC is about 30 ml per kg and the total lung capacity is about 50 to 90 ml per kg. So FRC is about 25 to 30% of the total lung capacity. So volume of the air which remains in the lungs at the end of the tidal volume is the functional residual capacity. And what is a tidal volume? It's the amount of air which is inhaled or exhaled with each breath under the resting conditions. So these things we have to keep in mind because when we are giving the mechanical ventilation strategies, it's important to understand the tidal volume and FRC at this level, which will help us in formulating the ventilation strategies. So FRC is the air which prevents the SpO2 fall when the babies have a periodic breathing. Let us look at now what is a dead space. The dead space is an anatomical dead space and an alveolar dead space. It's a part of the area of the respiratory system which does not involve itself in the gas exchange. Anatomical dead space includes the nose, the pharynx and the trachea and the bronchi where there is no gas exchange happens. These are conducting airways. The alveolar dead space are the air containing alveoli, but they do not have a blood flow in the adjacent pulmonary capillaries, so there is no perfusion. That's why the gas exchange does not happen. A physiological dead space is an addition of the anatomical and alveolar dead space and it amounts for about 2.2 milliliters per kg. The physiological dead space is 30% of the tidal volume, and factors which tend to increase this dead space we have to minimize when we are providing the mechanical ventilation. So what we have to take care of: the size of the ET tube, the circuits, any secretions in the circuits, the airway, the extension of the neck, the jaw protrusion. So all these factors have to be taken in account to decrease the dead space as much as possible.